So we'll be starting with session 5, which is titled Harnessing MDT Insights for Comprehensive Approaches in Primary Patient Care. And our moderators, Dr. Fail Ajil, Dr. Fatma Bshihri, and Dr. Layal Minoufi. We'd just like to announce a change in the schedule. The lecture Journey of Geriatric Approach in Primary Health Care by Dr. Nasser Al-Graini will be changed to tomorrow. And instead, today we'll have a lecture by Dr. Bassam Al-Budhi, Recharge Your Life. So there has been a switch between Dr. Bassam Budhi's lecture and Dr. Nasser Al-Graini's lecture between today and tomorrow.
We'd like to welcome our next speaker, Dr. Samia Al-Musallam. Dr. Samia is the chairperson of the Faculty of Primary Healthcare. She's a family medicine consultant in Ministry of Health with more than 30 years of experience, a fellow of the Royal College of General Practitioners, and has earned a diabetes diploma from Leicester University. Dr. Samia is passionate about the development of medical education in Kuwait. She is the co-founder of the Train the Trainers program, has participated in the establishment of the Professional Diploma in General Practice program, and had led the GCC Family Medicine Programs Collaboration Initiative in 2010, a trainer and mentor in the Trainer and Trainers program, and the tutor of the undergraduates in Kuwait Faculty of Medicine, and an accreditation surveyor in the Quality and Accreditation Department in the Ministry of Health. Welcome, Dr. Samia. The floor is yours.
Good morning, everyone, and thank you for the nice presentation of me, the introduction. Today, my talk will take you away from the traditional medical topics that you are usually used to. When we were in the process of preparation for the conference, I was approached by the scientific committee to choose several topics in order to present in this conference. And I chose several topics, and one of them was peak performance. And as I was told, the scientific committee unanimously voted for this topic and did not vote for other topics. And this was not surprising for me at all, as we doctors usually have an inner crave to perform better, and we have a crave to reach our full potential. So sometimes, as doctors or as any person, we get a little bit, overwhelmed with the tasks of every day that we are doing every day. We are overwhelmed with the amount of work. And so sometimes we start to doubt ourselves and to think, what am I doing here? Why am I not performing the tasks that are required from me, for example? So my talk today is directed to all doctors and to all residents, to mentors, to trainers, and to everyone who wish to improve their performance and to become more efficient in the task that they do every day. And we will understand why sometimes highly qualified, very smart people tend to perform far less than those who are less smart, let's say, or less qualified people. So to make this clear, let us understand what is peak performance. Okay. So peak performance is a level of exceptional functioning in which a person effortlessly performs an activity to the maximum of their potential or of their ability, while they are fully focused, immersed in feelings of confidence, engagement, and full enjoyment. So it's all about doing things that are really requiring high capacity, but doing it effortlessly, just like this gymnast. When you see this gymnast performing, you feel she's doing this very easy. But it seems that she has quite a huge capacity, a huge control of the task she is doing. How she is doing this? By becoming fully focused. You can see her, she doesn't feel the audience around her. She is fully focused with the tasks she's doing. She's fully immersed to the extent that she has excluded all other distractors from her. So just focusing with this fierceness on the task she is doing. So, to make this more clear, this is peak performance. We can say that peak performance it has maximum ability. It has to have laser focus of the task we do. We need to do the task with full confidence, at the same time with enjoyment and with effortlessness. So if I might ask you, in a scale from 1 to 10, how many of you feel that you are performing, or where are you standing with regard to peak performance? 1, which is very much under performance, and 10 is maximum performance, like the gymnasts you were seeing. So where are you standing, in the lower down, in the middle, or higher up? Middle, yes. This is not surprising, because to reach peak performance, it requires lots of skills. And usually these skills are not natural. They don't come to us naturally. So in order to understand how we can reach our full performance, we need to understand what are the factors that might hinder us and prevent us from reaching our full potential. So after reading many articles, many books, and reviewing lots of research, I came to the conclusion that peak performance, or the hindering factors to peak performance, can be boiled down to 4 major factors. The first one, which is a very important factor that affects our ability to reach peak performance, is suboptimal emotional regulation, or in other words, the level of mental fitness. And what I mean by mental fitness is the capacity to respond to life challenges with a positive mindset rather than a negative mindset. So whenever you are in a negative mindset, whenever you are in a lot of stress, our minds is shifted to survival mode. And when we are shifted to survival mode, we are switching, as you know, the fight and flight mode, or the fight or flight mechanism. And when we are in fight or flight mode, we cannot access our creative mind. We cannot access our full capacity. And this is one of the most important reasons why very much smart people or highly qualified people, they might not perform as expected from them, because they have issues with their mental fitness, or they have issues with reaching optimal emotional regulation. They are not resilient enough. But by resilience, I mean the capacity, our capacity to recover back from the negative feelings to be in a relaxed, positive feeling. And sometimes we have this capacity, but it needs to develop. It's not agile enough. We don't recover fast enough. So when we don't recover fast enough, this affects our performance. And as you know, our life is all about challenges. We are faced with challenges every day. So in order for us to be able to deal with the challenges of life, we need to develop our emotional regulation skills. And I will not be talking about it in details because I'm glad that there was a shift in the schedule and Dr. Bassam came, Dr. Bassam al-Badhi, he will have his talk after me, which I believe he will concentrate more about burnout and how to deal with burnout and with well-being. But I will only give you one hint here, which is the use of breath. You cannot imagine how powerful your breath is. I want you if you can just close your eyes for a few seconds. And I want you to think about a stressful situation, a situation that made you feel not comfortable and put you in a negative state, either anxious or angry or whatever mode of emotion that are negative. So when you feel these negative emotions, I want you to start to breathe. So inhale and count for 4 for inhalation. Hold your breathing for 7 counts. And exhale for 8 counts. I'm sure most of you will feel that the negative feeling that they were feeling just reduced. Maybe it didn't disappear, but I'm sure it's reduced. So your breath is an anchor. You can use it as an anchor wherever you feel that you are in a negative state and you want to shift to a positive emotional state. So I advise you to use your breath. It's free, it's available, okay? So the second factor which might hinder your ability of peak performance is cognitive overload. So cognitive overload is a state of mental exhaustion that occurs when the demands placed on your working memory exceeds the capacity. And I'm sure most of us, at one point of time, we were, or in most of days, maybe in our days, we are under cognitive overload. We are overloaded, bombarded with the task that we need to do every day. There is an overload at work. We are in short of time. We need to balance our family life. We need to balance our work life. We don't think that the day is enough to finish all the tasks that we want to do. I'm sure that all of you feel that. So when you are feeling this, it means you are under cognitive overload. So it means that you are putting a lot of toll over your working memory. And unfortunately, the system, whether it's the health system, and I'm sure all systems, work systems for any other branch, not only medicine, and even educational system, they are designed to put a huge toll over us. So they are adding on the cognitive load that we put on ourselves. To make this more clear, let us understand first how our memory, working memory, and where the working load is. So at any point of time, there is a huge amount of information that is entering our mind. Millions and billions of bytes of data are entering our minds. What we are doing is that all this data is going to our sensory memory. Our sensory memory, it acts like prompts. So it just gives us attention to things we believe that are important for us. So the sensory memory is very, very short memory. It takes only a fraction of seconds for the information that goes inside our sensory memory. Then all the rest of information that we don't think it's important will be immediately forgotten. So we apply filters. Some of it are conscious, and most of these filters are subconscious. We are not even aware of these filters. We apply these filters to limit the amount of information that will go from the sensory memory and enter to the data processing area, which is our working memory. This is here the factory for us, for every decision making, all the problem solving, all the information that we believe are important, we process them here in the working memory. And the rest, it will be, it's a short-term memory, this one. The rest, if we don't use the information in it, it will be forgotten. The issue is that this working memory is limited. And it's limited to an average of 7 pieces of information per time. So at any point of time, our mind cannot work on more than 7 pieces of information. Okay. So at any point of time, I'm sure now, if you just think about the amount of sensory input that is coming to your mind right now, you will feel that you have all the senses. You are, for example, tasting your coffee, you are feeling the cup in your hands, you are feeling the cold in the room or the heat in the room. Maybe some of you are seeing their mobile, some of you are listening to what I'm saying, some of you are watching me, some of you are. So all these huge amount of information, unless we ignore some of them and focus on certain aspect of the information, we will not be able to process the information efficiently. Okay, and this is very important because in many times we think multitasking is a good thing and it can help us to achieve more. But multitasking can be your worst enemy and can be the worst thing if you want to excel your performance and if you want to reach your full performance. Because, after the information is going from the working memory, here we rehearse all the information. For example, then this information will be coded. All information, it has to go to the long-term filing system of our brain, which is our long-term memory. And this is an unlimited capacity. But for it to be efficient, we need to rehearse things, file all the information very clearly, so we can form later on habits and we can later on retrieve the information that we want to work and help us to solve a problem in this place, which is the working memory. So the most important message from this slide is that for you to understand that your working memory is limited and it cannot take more than 7 pieces of information in one time. So let us now learn some strategies that will help us to improve our working memory. One of the most important strategies that can be used and which are mastered by peak performers like, for example, athletes, like top surgeons, they are masters in elimination of distractors. What I mean by that is that they have the ability to focus fully. They have this laser kind of focus on the task at hand. And they have practiced this, so it's like a second nature for them. So, for example, during an operation theater, if the surgeon is doing a difficult operation, he will ignore all types of uncomfort, pain that he might feel, the cold in the room, the noise, whatever. He is fully immersed in the task he's doing. How did he achieve that? By elimination of distractors, by focusing and directing their focus to a certain task. For us, we are faced every single time by a huge amount of options. And if we want to excel in one of these options, we need to learn how to trade off. We need to learn how to choose and select an option and focus on that option and distract or eliminate all other options. The second strategy, which is part of elimination of distractors, is that peak performers, they are masters of applying positive constraints or applying rules, because a rule restricts freedom in one direction. Automatically, when it restricts the freedom in that direction, it will give you more freedom in another direction. For example, for any resident who's preparing for their final exam, you don't expect yourself to reach your peak if you want to have everything, if you want to have a relationship with your friends, to keep the good time that you have with your family, you want to go to the gym, and you want to watch your favorite show. So you need to apply restraints on yourself and see. And this is all about options. And we will see what else later on, what else that might help you to eliminate distractors. The second strategy, which is also very helpful, which is practicing mental simulation or visualization. And there is lots of research on it. What I mean by mental simulation is to visualize a task that you need to, that has to be performed, for example, but you do it beforehand. You do it as if it's happening with all the details of it. This is very much practiced by athletes. Most top-performing athletes, they practice visualization. They see the whole game before it happens. They see it as if it's happening right now in their mind's eye. This helps a lot in reducing the cognitive load. By doing this exercise, we are helping our minds to retrieve all the information from long-term memory. So we are giving our working memory a space to work on other information. That's why mental simulation is very powerful. The third strategy is good habit formation. And habit formation has a very, very important role in hindering or helping us to reach our full potential or peak performance. Because we humans are creatures of habits. And whenever we are not forming a good habit, a bad habit is being formed automatically. So at any point of your time, if you are not making good habit, be sure that a bad habit is forming at the same time. That's why it is very important to be aware about ourselves, to increase our self-awareness, and to understand where are we standing, what are the habits that I am performing that might prevent me from reaching my peak performance, what bad habits that I need to get rid of in order to achieve my peak performance. And in order to have this clarity of thought, we need to have clarity of purpose, which is most of the time, unfortunately, many of us, we don't have this clarity of purpose. And that's why we are unable to form the habit, because we don't have the direction. We don't know exactly where are we heading. And this is why, because we don't have very clear purpose, this is why New Year's resolution, I'm sure many of you at the end of each year, you have resolution for next year. For the ladies here, most of you will be about losing weight, maybe. Some of you about reading more, some of you about making a habit of exercise. Maybe you start in January, for the first week of January, then maybe in the second week you are just, falling apart, falling behind, and then by the third or fourth week of January, you are back to your previous state. So why is that? It is mainly because you failed to form a habit of the behavior that you are, of your intention. And your bad behavior, which is preventing you from reaching that good behavior, is the one which is taking place. And habit formation have the main role is that it will help you to do things automatically, effortlessly, and this is exactly what is peak performance is about. It's all about reducing the cognitive load to help us to perform with ease or with the flow. Habits, they will not happen without sustainability and without consistency. And we will learn later, I will give you a guide of how to form habits. The fourth very important factor which hinders our ability to peak perform is to have clear purpose and to be passionate about this purpose. Because, and I believe this is maybe one of the most important factors, because the strength which holds you to your purpose is not your strength, it's the strength of the purpose itself. What I mean by that is that your purpose should be very personal to you, should be very meaningful to you, and should be very, you inject it with lots of emotion. If your purpose is just logical, it will not have fire enough. It will not sustain you to continue doing it, okay? So this is very important. When you are working on your purpose, you need to do lots of inner work to understand what are your personal value system. And this is why sometimes most of leaders, they are suffering that their staff, they are not performing the way they do. It's because the staff purpose is totally different from the leader purpose. So that's why the leaders will not be able to make their staff work the way they want them to work. Now, we are going to learn some steps to help you get rid of your old bad habits and help you to develop new good ones. The first step, as I said before, is to work on your purpose. So working on your purpose, you need to decide on your life priorities. What do you want to do? What is important to you? And when I'm talking about this, it has to be very, very personal to you. Because if it's not personal, you will not be able to carry it and continue to sustain it. You need to know your own value system. After understanding your personal value system, then you need to define your purpose for the task that you want to develop a habit out of it. And this purpose, it has to be extremely clear. It has to be crystal clear. It has to be very big. And it has to be very, very emotionally charged and meaningful to you. When you write it down, you are crystallizing it. So this will help you to continue on it. Then make a list of the things that are not contributing to your priorities or to your personal values or the wrong habits that you are doing. And then decide on which habit you want to start or decide on which habit you want to get rid of. Choose only one habit at a time because you want to reduce the cognitive load. And it's a very wise approach to when you are deciding on your which habit to start, to think about it as an experiment or as a temporary thing. Because when you think about this is, for example, I want to lose weight, so I want to cut down chocolate. So if you cut down the chocolate, let's say for 1 month, it's easier on your mind to take it than when you tell your mind, I will stop eating chocolate forever. And there is lots of evidence that finds that this putting it as an experiment can help you to continue with your habit. The second step, which I am quoting from James Clear book, Atomic Habit, which is a very helpful book, whoever who would like to read this book, is that to start very small.
دكتورة سامية آسفة بس 5 minutes left, please.
Okay, راح أخلص إن شاء الله 5 minutes. So start very small and increase very slowly. Because the aim is to be consistent so that we can have sustainability. And always remember that success is a few simple disciplines practiced every day, whereas failure is few simple practices repeated every day. So don't underestimate how small are the good habits you are practicing, because it will accumulate to become big and it will accumulate to become a behavior. And don't underestimate the amount that, the small chocolate that I take every day, it will not affect my weight. Okay, because it affects your weight, even a small one. So we need to be clear about that, okay? And when you make it very, very small, so there is no need to motivate myself a lot. It will be very easy to go on with the task. The second step is to divide your habits into chunks. For example, if you are establishing reading, you want to read more books. So instead of reading a chapter every day in one setting, you can divide it into 3 times a day, for example. If you want to start doing push-ups, for example, instead of starting with 5 one time, do it 2 in the morning, 2 in the evening, and then build on it gradually. So go simple. Whenever you want, just think, how can I simplify this more? Because remember, the road to 1,000 miles starts with 1 step. And when you slip, which is, we are all human, this can happen to all of us, just go back to it. Don't tell yourself, finish, I skipped it, I will not go back, I failed, okay? Because also there is lots of evidence and research that when you slip for 1 day and go back to your habit, it will not affect the consistency and the sustainability of your habit. This is important, this point of consistency and not perfection. Because sometimes we tell ourselves, unless I can do it perfectly, I will not do it at all. So don't go for perfection. Go for consistency. Go for sustainability. In order for you, when you slip back, just reflect, why did this happen? It's a good practice to plan for failures. For example, what I mean by that is to think about option. If this not happen, or if this doesn't succeed, I have other option to do. And very important is to be gentle of yourself, because sometimes we are very much harsh on ourselves. And always go back to your purpose. Going back to your purpose will put you back on track. Okay, don't rush, be patient, because what we want is sustainability. And this is very important, and it has also, there are lots of studies that celebrating your achievement will increase dopamine and will increase noradrenaline, which are the feeling good neurotransmitters. And it's found that when we have higher level of dopamine, we can easily continue with our habits more than when we have low levels of dopamine. And this is called the stimulation of learning through reward. So just to wrap up, the 4 pillars of peak performance are being mentally fit, minimizing the cognitive overload, to be clear about your purposes and your personal value system, and to develop positive habits that will help you achieve or perform better. And the 5 steps that I mentioned about building habits is to set your purpose, start very small, increase very slowly, break your habits into chunks, get back to track quickly, and stick to a sustainable pace, and don't forget, celebrate your small wins.
Thank you, Dr. Samia, for this very interesting. Thank you, Dr. Samia, for this very interesting lecture. We actually have a few questions, if you may. The first question is how to deal with the effect of burnout on peak performance?
Yes, by increasing your mental fitness. It has, it's a very big topic, mental fitness, and how we increase our mental fitness. You need to practice many things. I'm sure Dr. Bassam will talk about it in his burnout session, but using your breath is, as I mentioned, this can help a lot if you don't have other information.
Okay. And multitasking is a pillar in family medicine clinic.
Yes.
Do you recommend that we change our approach?
Yes, definitely. I recommend that you change your approach by dividing. I'm sure to divide the tasks into at one point of time. You know, you can do a lot of things, but at one point of time, you cannot take more than 7 information. Mm-hmm. So you can divide your days for several different tasks. The other thing is to always have the clarity of purpose, why you are doing the task that you want to do. If all are aligned, then you can divide your time, then it will be achievable. Otherwise, if you just take more and take more, you will not go anywhere.
Thank you very much.
You're most welcome.
And we'd like to ask for Dr. Dina to come on the stage. Thank you.
We would like also to give certificate of appreciation for our moderators. Dr. Faye Al-Ajil.
And now it's our pleasure to introduce our next speaker, Dr. Nasser Bahbahani. He is consultant pulmonology in Mubarak Hospital. He is president of Kuwait Thoracic Society and member of Department of Medicine in Kuwait University. Welcome, Dr. Nasser, and the floor is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. It's very impressive. I would like to congratulate the organizing committee and everybody who has been behind this conference. I'm actually proud to be part of it, so thank you for giving me this opportunity. Actually, I made a mistake because I am an older person. When they told me Grand Hyatt, I went to Hyatt Regency, thinking that this was the venue. So, this is my conflict of interest. And I know all of you don't want to be here, want to be, راح أعطيكم فرصة تفكرون إنكم قاعدين على البحر. You are thinking. And what I want you to think about, just give you 1 or 2 minutes. What are the challenges in asthma management? So just give yourself half a minute or a few seconds just to think what are the challenges in asthma management. I'm sure all of you have some ideas. We will not, unfortunately, we cannot make it interactive. But let me tell you, I think these are the real challenges. The first thing is diagnosis. Our life would have been much easier if we have a blood test like diabetes, or if we have a measurement which is solid like hypertension. But we don't. And to be honest with you, the patients who comes to you with cough, which fills your clinics, there are so many conditions that can mimic asthma: upper airway cough, bronchitis, anxiety, interstitial lung disease, so حوسة. So this is a reality. And also lack of spirometry in primary care. This is a problem. And compliance. We think our patients don't listen to us, and sometimes it's their fault, sometimes our fault. And there are too many choices. Now the choices of inhalers is too many. And there is actually in the guidelines, there is track 1 and track 2. وإحنا مو ناقصين guidelines. But I'll try to make it simpler for you. This is a case that it's a real life case, a 28-year-old man who is healthy and fit. He's unmarried. He smoked vape for 2 years. He presented to me in September 2023. He actually left side chest pain since June. No other symptoms. Maybe dyspnea, he was vague. He saw a primary care physician. He thought this was muscular pain, giving some muscle relaxant analgesics. Then he saw a cardiologist because he worried he had full cardiac workup, which is normal. Again, he saw another primary care physician, and he was started on Symbicort, which is a sort of second-line asthma treatment as a trial for 2 weeks. When he came and saw me, physical exam was normal. I did chest X-ray just because he had this pain. I wasn't worried about pneumothorax. I did spirometry, which was completely normal. And I was curious. This patient did not sound like asthma. Why he was given this inhaler? So I asked him, why they gave you the inhaler? So he told me, the day I went to the primary care, they told me, do you have dyspnea? And he said, شوية كانت رطوبة. He said, عندي حشرة بالصدر. He was given this inhaler. Actually, the real story behind this case, and his spirometry was completely normal. The real story behind this case, كان حب زميله معه وكان يبي يتزوج، بعدين أهله رفضوا وانصدم الولد. He has a broken heart, basically, which is a real syndrome. And he told me, this is my problem. The reason I present this case, I tell you, we take the diagnosis of asthma easily, and we prescribe medication easily. And we have to change this approach. Asthma should be done, a diagnosis should be more solid, okay? And this is, I show this in many of my talks. This is called Andrew Bush. He's a famous pediatric respirologist. And in one of his writings, he said, we propose that factor diagnosis of asthma has been trivialized. And sometimes we say, هذه حساسية، اخذ البخاخ وشوف شلون يصير. Inhalers dispensed for no good reason and have become a fashion accessory. The result, the fact that asthma is a killing disease, if not correctly managed, is overlooked. And there is no other example where a chronic disease is, should be objectively diagnosed. So this is my message about diagnosis, which I think the people who have seen my talks, I always try to emphasize it. Now we talk about the part of the guidelines. You know that recently there has been some changes. This is in 2023, Global Initiative of Asthma Guidelines. And basically the idea here in asthma, and this is something that you need to realize when you're talking to the patient. Your aim is two things, is to control symptoms and prevent exacerbation. And sometimes the patient doesn't realize this. And sometimes we as physicians don't realize this. So this is our aim. We look at future risk of exacerbation as well as current symptoms. So this is current control, future risk. This is, I think, just to make it simple, this is the older guidelines. Basically, the first thing we say, if you have intermittent symptoms, you take as needed short-acting beta agonist. And then we build it up, adding inhaled steroids, adding long-acting beta agonist, maybe adding antimuscarinics, And then now, this is not the purpose of the talk, but there is in severe asthma, there is phenotype-based, which is biologic agents. And there are several now that are available and can make a difference in the people who have severe asthma. And here, the short-acting beta agonist is a reliever in all of these steps. This was the previous guidelines. But with studies and with experience, people like their short-acting beta agonist, and so they drift towards it because it gives them immediate relief, okay? And it creates a dependence on short-acting beta agonist. It has nothing. If somebody takes it alone, it increases the risk of exacerbation. It controls symptoms, but increases the risk of exacerbations. I'm going to give you another case, a real case. A 21-year-old woman. She's a university student. She had asthma since childhood, and actually I knew her for a long time. During childhood, she had severe persistent asthma. She was admitted to hospital several times. By the age 13 to 14, her symptoms have improved. Now she is no longer needing admission, and the symptoms became intermittent. She lost follow-up for a few years, and she came to me in June 2021. She said, I feel good. I no longer am staying in the hospital. Her medication, she relies on salbutamol as needed, and she needs it few times per week, and she is happy. Chest exam, mild wheezing. What is the next step? I did spirometry. Okay, so even in this case, important to ask the patient when they are happy, what happened when you do exercise? Sometimes patients adjust their lifestyle so they feel to accommodate their disease. What happens when you get a cold? Do you get exacerbations and nocturnal symptoms? If you dig deep into this history, you will get more data than the apparent the patient is happy and she takes the salbutamol only a few times a week. Her spirometry showed basically FEV1 was around 46.5%. She's used to chronic asthma, she used this, and there is a big improvement after salbutamol. So this tells you she is undertreated. Her asthma is not controlled. There is big improvement with bronchodilators. So what I told her, you should not do this. You have to take controller medication regularly. This message, it has to be clear to the patient. Any patient, in my opinion, with adult onset asthma or asthma in childhood sometimes goes away and come back, you tell them this is a lifelong disease and you should be on a lifelong treatment. If you are clear in your message, the patient may accept it. If you are a physician in doubt, the patient gets this doubt. So I told her this, but about more than or almost a year later or 2 years, she had progressive dyspnea over 4 or 5 days. She was taking Ventolin nebulizer at home without help. On examination, she was tired, heart rate 120, respiratory 35. She had severe asthma exacerbation, mild expiratory wheeze. And she was admitted to ICU because we were worried. We treated her with steroids, with bronchodilators. And by the way, in severe exacerbation, even if they are tachycardic and you are sure they have asthma, salbutamol helps them. It doesn't make them worse if you are sure they have asthma. So there is it's not contraindication in exacerbation of asthma. Different from older patients, COPD. And a day later, she developed swelling in her neck. So she developed paratrauma from the severe asthma. She developed basically pneumomediastinum. So this doesn't require actually chest tube. Thank goodness she eventually, this is the air in the soft tissue, which you can see here. So air in the neck, okay? So, but thankfully she improved and she actually was still, and then when I talked to her, she said, كلها من طلبات. So what does this have to do with طلبات? Actually, this patient had, because she's so dependent on her short-acting beta agonist, she had inhaler in her bag, in her drawer, in her car, in that living room, and she also ordered it from Talabat. They deliver, because it's over the counter, and they deliver medications. So that's how she became dependent on short-acting. So this is one of the reasons that the guidelines has been changed. And there is something called airway remodeling, which is basically patients untreated, you get more fixed airway obstruction. And there is patient remodeling. If patients, and also actually we in Kuwait and primary care, we help patient remodel because we over-rely on nebulized treatment during exacerbation. A lot of patients, when they come to you in the primary care, you give them the scenario, take nebulizer 3 times a day for 4 or 5 days. So they become, this is the treatment which is concentrate on symptomatic treatment. So patient modeling, we physicians sometimes contribute to this. So this is the guidelines, and I'll try to explain to you the track 1 and track 2. Basically, what you want your attention that now the reliever can be inhaled corticosteroids and fast-acting bronchodilator. Now they call it another term, AIR, which is inflammatory reliever. Airway inflammatory reliever, because it contains inhaled steroids, or it can be inhaled steroids, and whenever they take short-acting, they take inhaled steroids. The patient will not take 2 inhalers. It will come in the future. It's not available yet. A combined inhaled steroids and short-acting beta agonist. In track 2, of course, it can be short-acting beta agonist alone. The main difference here between track 1 and track 2 this is track 1, that you don't no longer give the patient a choice, and we usually take only short-acting beta agonist as needed. In step 1 and 2, you give them as needed inhaled corticosteroids and fast-acting formoterol, okay? And the reliever, you do this. And the way to do this, it doesn't work for everybody. I'll show you an example of a case, and then you build it up. In reality, we want a lot of patients come to us when they are symptomatic. And I actually give them regular treatment to start with. I don't rely on this until I achieve control. So this is something you have to bear in mind. And you build it up with a low-dose inhaled steroids or medium, and then you can add the LAMA or the anti-leukotrienes as you build up the treatment. And this is the new term I told you. The reliever is anti-inflammatory reliever, AIR. So because whenever they take the reliever, they take something which helps them in the control, okay? The difference between track 2 is you tell them you take inhaled steroids plus short-acting as whenever you take it. And if in the future it becomes with short-acting, this might be an option. Step 2, you low-dose inhaled steroids, and then you build it up. So the only difference here is between step 1 and step 2. The rest are really the same. Just to help you with the terminology, reliever means symptoms relief. So it's a mainly short-acting. You know what controller is. So it's both anti-inflammatory, which it has to contain inhaled steroids, and the maintenance treatment that are regularly scheduled twice daily treatment. This is a relatively new concept when you talk about anti-inflammatory reliever. That something contains inhaled steroids with bronchodilator, either a short-acting or a long-acting bronchodilators. And then there is what's called the MART, maintenance and reliever therapy. Basically, you use an inhaler which can do both. You can give it regularly, and they use it also as a one inhaler. For this policy to be successful, the patient and the physician need to trust the inhaler, need to trust the device, and it takes time for the patient to trust the inhalers. Whenever he takes exacerbation, he uses the nebulizer, this is not gonna work. So you need to build this trust, okay? So why make this change? There is evidence behind it. In step 1 and 2, there is studies which compared actually short-acting beta agonist versus what's called as needed inhaled steroids plus fast-acting beta agonist. And they compared them also to low-dose inhaled steroid. There are many studies which made the comparison. And basically, the risk of severe exacerbation was actually reduced because it gives the patient freedom to increase their dose. And this can be, for example, in Symbicort, it can be increased up to 12 puffs per day, okay? In the beclomethasone, formoterol, it can be increased up to 8 puffs per day. So it gives them freedom to increase their dose as they have increasing symptoms. This is a study which is published in New England Journal of Medicine, basically compared short-acting beta agonist alone, maintenance low-dose inhaled steroids plus short-acting as needed, and the as needed needed inhaled steroids long-acting, which is if you like, the SMART. And basically what it shows, that the one here, the green or the blue, had lower risk of severe exacerbation compared to the others. And the risk of exacerbation all exacerbation was almost the same between maintenance inhaled steroid and as needed inhaled steroid long-acting. So this is the evidence behind it. Another one, actually, this is in the study, this is in the Cochrane analysis, same conclusion, that the as needed inhaled steroids long-acting beta agonist was better than short-acting alone or low dose and short-acting as needed. For step 3 and 5, there is some evidence that basically if you use what's called MART, maintenance and reliever, instead of telling the patient whenever you have symptoms you take Ventolin or salbutamol, you can take the budesonide long-acting beta agonist. And there are studies that in this approach, also the risk of exacerbations is less. So there is evidence behind this change in the guidelines. And this is one study which it is not available yet, but I wanted to tell you about it, which is albuterol budesonide. Albuterol is a short-acting beta agonist, still not licensed in Kuwait, and they compared it as a rescue inhaler. So it will replace Ventolin, and it showed it to be better than using Ventolin as a rescue inhaler across all degrees of asthma. So in summary, this is why GNET track 1 is preferred, that it's a simpler and it avoids the use of short-acting beta agonist. And step 3 and 5, if you use this, what's called airway inflammatory reliever, it helps also to decrease the risk of exacerbations. And the practical advice you give to the patient, there is actually done a practical study. Of course, you have to teach the patient. You have to tell them, you take this with you, you take it with needed, you take one at home and one at night, and it needs, the most important thing, you get the patient to trust their device. Not everybody agree with this. Some people say, and it may not work for all patients, because there are some patients who just don't get the idea, I take it as needed. So some patients, it's better to give them regular treatment. So the take-home message, do I have time to present the case? Yeah? The take-home message is diagnosis, diagnosis, diagnosis. Spend time on documenting the diagnosis. I think you are better in treating asthma if you recognize what is not asthma. That the second, whenever a patient comes with symptoms, ask yourself, is this symptoms related to asthma or not? And as needed therapy may not work for everybody, but you have to trust the patient. And I will show you an example here. This is a 25-year-old woman. She's a non-smoker. She was fresh graduate. She came to me in July 2022. She had cough, wheeze, dyspnea with exercise. She had nasal blockage. She was already actually taking Sympicort. She had no pets. Her chest is clear, but her FeNO was very high. The people who are not familiar with FeNO, it's exhaled nitric oxide. The cutoff is less than 30. In asthmatic or uncontrolled asthma, especially eosinophilic asthma, you see the level is high. So it was 117. I did spirometry for her, which is basically actually normal, okay? But her FeNO was high. So how do you classify this patient? Is she intermittent? Is she severe? Sometimes it's difficult to classify it at the beginning. You need time. So I told her, you have to continue your medication. She continued her medication 2 puffs twice a day. Her eosinophils was high, total IgE was high. She came back 2 weeks later, so I told her, take it as needed. She didn't want to take it regularly, or actually was taking Sympicort. 1 puff once a day. Within 2 months, she came with an upper respiratory tract infection. Despite increasing the dose to 4 puffs per day, she had severe exacerbation and she required admission to hospital. Why did this patient develop severe exacerbation that led to hospital admission? Probably her asthma was not controlled. The dose that she was taking was not enough. And this is what airway inflammation does. This is in a study. This is the patient before inhaled steroids, a lot of eosinophilic infiltration, epithelia, and this is after inhaled steroids. The airway inflammation is controlled. So probably it was a mistake decreasing the treatment for her. It would have been better to give her regular treatment to achieve control. This patient was discharged, she improved, and then about a year later, she was taking 4 puffs a day. She was happy. She came with a mild respiratory tract infection, but this time she did not exacerbate severely, because the main reason she did not exacerbate the second time, because her asthma was more under control. And I know you all experienced during the heavy rain in every year almost, a rush of patients with acute exacerbations. Usually these patients are not controlled, and when they get the allergic challenge from the rain and things, they get exacerbations. So I think this was my last slide, and thank you all for listening.
Thank you, Dr. Nasser, for the great talk. We have a few questions for you. The first question is spirometry a must to diagnose the asthma? And should we refer each patient for the secondary care for the diagnosis, or should we depend on only the symptoms?
I think spirometry is a must. If you don't have it in primary care, I know for sure. But of course, if somebody comes with acute symptoms, you may not have the luxury to wait for the spirometry. But what you should do, refer all patients. Spirometry is, and if there are inhalers, you ask for pre and post bronchodilators, and you instruct the patient not to take their inhalers the night before they do spirometry. I think spirometry is available in all the general hospitals. Besides, I don't have it in the slide, there is a sort of positive signs. For example, be wary of patients who have dyspnea alone without cough or wheeze. Asthma doesn't present like this. Be wary of patients who have only with cold and the rest of the year are negative, and they always have itchiness and throat, upper airway cough. The age, somebody comes to you first time after age 50, first time symptoms, may have asthma, but be careful with this. So there are a few things that can help you in clinical diagnosis.
Okay, thank you, doctor. The second question is, if the patient has seasonal asthma, is it okay to take the controller only during these seasons?
Actually, I personally struggle with this. I don't think that there is pure seasonal asthma and the rest of the year they are completely normal. I don't think this is the case, because usually they have less symptoms during off seasons. And I don't know what is seasonal asthma, because even if you take pollens, it's to increase in September, but colds, it can occur any time of the year. So there is two reasons that one thing that this patient may not have asthma. They may have a prolonged cough after upper respiratory tract infection, and they improve with whatever symptoms, and the next time they get home. So some of these patients, I think they don't have asthma. So this is my opinion, that check with them between the seasons.
Okay, thank you, Dr. Nasser, and I hope now you accept our appreciation certificate.
Thank you.
Thank you to our valued speakers. We will have a break until 1:15. Thank you.